Hello everyone, welcome to Medagac. Today we are going to discuss about nephrotic syndrome. Before starting, just to inform that, you can read the full article of nephrotic syndrome, the link is given in the description box. Now come to the lecture, we will discuss the lecture in 6 parts. Those are 1. Description about nephrotic syndrome. 2. Causes, that is primary causes and secondary causes. 3. Clinical features. 4. Pathophysiology. 5. Investigations. 6. Treatment. Nephrotic syndrome is a disorder of kidney in which so many abnormalities can be found in the kidney due to some pathology. The child can present with massive 1. Proteinuria. 2. Generalized edema. 3. Hypoalbuminemia and hyperlipidemia. Now let's learn the causes of nephrotic syndrome. Primary causes are congenital nephrotic syndrome, membranous nephropathy, focal segmental sclerosis, diffuse mesangial sclerosis, minimal change disease. Secondary causes are infections, like syphilis, HIV, malaria, cytomegalovirus, toxoplasmosis, rubella, hepatitis B, syndromes with associated renal disease, Lowe syndrome, nail patella syndrome, Dennis-Rash syndrome, nephropathy associated with congenital brain malformation, systemic lupus erythematosus, hemolytic ureic syndrome, drug reactions, toxins and mercury. Now come to the clinical features. The onset of edema is insidious in nature, and first appears surrounding the eye, then slowly progress to become generalized and forms ascites, hydrothorax and hydrocele. This is facial puffiness in nephrotic syndrome. This is ascites in nephrotic syndrome. Here we can see the pitting edema of feet. Other clinical features are 1. Sometimes, if infection is the cause, then slight rise of temperature can be noticed. 2. Severe muscle wasting can be seen. Now let's learn about pathophysiology of nephrotic syndrome. Massive proteinuria and hypoalbuminemia. Any structural or physiochemical change can affect the GBM, glomerular basement membrane, which may lead to increase the permeability to plasma protein, which will enhance protein excretion and cause massive proteinuria. As a result, serum albumin will decrease and will cause hypoalbuminemia. As a result of decrease in serum albumin, drop in plasma oncotic pressure will occur. Generalized edema. Now the decreased intravascular volume and renal blood flow will cause secretion of renin from renal juxtaglomerular cells. Then renin further stimulates angiotensin-aldosterone axis. This will promote the water and salt retention by kidney. Now this water and salt retention along with hypoalbuminemia will cause localized edema at first, and further this will form generalized edema. Hypolipidemia and lipiduria. Here, hypoalbuminemia triggers the synthesis of lipoproteins in the liver, or sometimes massive proteinuria causes loss of an inhibitor of their synthesis. This will cause hyperlipidemia and lipiduria. Now come to investigations of nephrotic syndrome. Urine examination. Heavy proteinuria, 3+ to 4+, hyaline and granular should be present. Serum albumin. This will be low and value will remain less than 1 gram per deciliter. Hypercholesterolemia. This may show milky appearance to the plasma. Blood urea and creatinine remains in normal range. Antibody titer. IgG will decrease but IgM will be elevated. Okay, now let's start the treatment part. There are mainly 2 types of treatment done in nephrotic syndrome. One is supportive treatment and another one is specific treatment. Specific treatment is done by 1. At first initial therapy. 2. Treatment in case of frequent and infrequent relapse. 3. Treatment in steroid-dependent nephrotic syndrome. 4. Treatment in steroid-resistant nephrotic syndrome. Now let's learn about the initial therapy. Low-salt diet intake. Using diuretics to excrete extracellular water and reduce edema. Diuretics used are furosemide, hydrochlorothiazide or metolazone, and spironolactone. ACE inhibitors, enalapril or ramipril is used. 20% salt-free albumin at the end of albumin infusion if serum albumin is less than 1 gm per deciliter with hypovolemia. Now let's start the specific therapy in details. At first, the initial therapy. In initial therapy, the drug used is prednisolone. At first, it is started with 2 mg per kilogram per day, divided into twice or thrice doses for 6 days. Then 1.5 mg per kilogram on alternate day at single morning dose for 6 days. Most patient gives response by the end of second week of prednisolone therapy. Those are called early responder. Few patient responds after 4 to 5 weeks of prednisolone. Those are called late responder. If not responded till 8th week of prednisolone, then those are known as steroid-resistant nephrotic syndrome. Now let's know the treatment in frequent and infrequent relapse cases. Relapse in nephrotic syndrome signifies edema. First morning urine sample contains 3+ or 4+ protein for consecutive 3 days. Infrequent relapse means less than equal to 3 relapses in a year, and frequent relapse means greater than equal to 4 relapses in a year. Treatment of infrequent relapse in nephrotic syndrome. Prednisolone 2 mg per kilogram per day, divided into twice or thrice doses until urine protein negative or trace for 3 consecutive days. Then 1.5 mg per kilogram on alternate day single morning doses for 4 weeks. Treatment of frequent relapse. This treatment is same as steroid-dependent nephrotic syndrome, discussed in next section. Treatment of steroid-dependent nephrotic syndrome. This is known as occurrence of 2 consecutive relapses during alternate day prednisolone or within 14 days of stopping prednisolone. Initially, prednisolone is used 0.25 to 0.7 mg per kilogram for alternate day and single dose up to 9 to 12 months. Or levamisole 2 to 2.5 mg per kilogram on alternate day for 1 to 2 years. Adding initially continuing alternate day single-dose prednisolone 0.5 to 0.7 mg per kilogram for few weeks, then gradually taper until it reaches 0.3 to 0.5 mg per kilogram, and stopped. Cyclophosphamide 2 to 2.5 mg per kilogram per day for 12 weeks in addition with alternate day single-dose prednisolone 1 to 1.5 mg per kilogram for 12 weeks. Cyclosporin 4 to 5 mg per kilogram per day in 2 divided doses for 1 year, in addition with alternate day prednisolone for 12 weeks. Mycophenolate mofetil 20 to 25 mg per kilogram per day in 2 divided doses for 1 to 2 years with tapering dose of prednisolone. Tacrolimus 0.15 mg per kilogram per day in 2 divided doses for 2 years, in addition with alternate day prednisolone. Rituximab. This is a monoclonal anti-CD20 antibody. This is useful in patients who shows toxicity to other drugs. Now come to the treatment of steroid-resistant nephrotic syndrome. Cyclophosphamide 2 to 2.5 mg per kilogram per day oral for 12 weeks, in addition with alternate day single dose of prednisolone 1 to 1.5 mg per kilogram for 12 weeks. Pulse therapy, INJ. Methylprednisolone 30 mg per kilogram on alternate day, total doses 3 to 6. In refractory SRNS, the dose is continued once in a week for next 8 weeks, then twice a month for next 2 months, and then once in a month for next 6 to 12 months. Followed by alternate day single-dose prednisolone starts at 1.5 mg per kilogram, then tapering up to 0.25 mg per kilogram for 4 to 12 months. Injection cyclophosphamide. It is given with dose of 500 mg per square meter IV for 6 months. Cyclosporin, 4 to 5 mg per kilogram per day in 2 divided doses for 1 year, in addition with alternate-day prednisolone for 12 weeks. Tacrolimus, 0.15 mg per kilogram per day in 2 divided doses for 2 years, in addition with alternate-day prednisolone. Rituximab. It is given with dose of 375 mg per square meter per week for 4 weeks.